All right, so those are two ways we could test strength. Now, there's a lot of other ways we could do it. Advantage of the manual muscle test. What do you think the advantage is? What did I say? So I can feel it. That gives me a lot more information. Yep. Fast. Fast, equipment free. Yeah. Disadvantage. The person stronger than me, or yeah, or if their activity, yeah, that's a big difference. A manual muscle test for the lower grades, very accurate. For the higher grades, there's a lot of flaws to the higher grades. But for the lower grades, we do a good job. Yeah. Four-way hop test. That's another one. Problem with it? What are some of the problems with it? Yeah, yeah. So is it truly accurate? Absolutely. So there's some measurement error there. Good. Any other disadvantages you think? Yeah, I was a little nervous when I saw what kind of shoes he was wearing. I go, oh boy, am I gonna get a phone call from my boss saying, Josh, in your lecture class, did you get the well-dressed student and had him jumping around on the freshly waxed floors? Well, yes, I did. Well, I don't see the problem with that. Yes. Um, so yes, there is a risk of injury there. Absolutely. Any others you think? Um, did I tell you guys where I work? I think I skipped that last time. So like I said, I've worked with some of the best athletes in the world, Olympians, NFL, Major League Baseball, high levels of basketball, but not NBA. I did that for some years of my career. I am now in home care physical therapy, so I go around to people's homes that can't leave. Most of the time, it's geriatric that's either medically unsafe to leave or there's a high risk of falls. So, if you guys think of grandma, do I want to make grandma do a four-way hop test? No, right? Because of the risks of injury are high. Does grandma ever need to jump? Some grandmas do. And I drive by some of those pickleball games. I got to tell you, there's a lot happening there. But it's some patients, it just doesn't make sense. For grandma, my manual muscle test is good enough. I don't need much more than that. But there's a lot of ways we can measure strength. Those are just two easy examples of some very different tests that could apply to different populations. So if we see that somebody has a strength deficit, well, what do? Strengthen them. There's a few ways we could do it. Broadly speaking, strengthening exercise, weights, bands, body weight. There's a million ways we could do it. Aquatic, being in the water, I think we talked about a little bit last time as well. That could be part of it too. Or we could use something like plyometrics. Those are jumping exercises to develop explosive power. In general, if I'm doing a manual muscle test, the person is probably going to have some sort of basic strengthening exercise program. If I need to use the four-way hop test, they're probably going to need some more advanced strengthening like a plyometric exercise. Does that make sense? Range of motion. So we can test range of motion. Too easy way to do it is with a goniometer, which is that tool, that little plastic tool that's up here measuring knee range of motion. There's some different ways we can measure with a tape measure as well. The goniometer is what I use the most. It's the class that I come from. All we do is manual muscle testing and goniometry. Those are the two things we learn in that class, every single joint and muscle of the body. So that's the most common one that we get to use. We get to compare right versus left on that person, but we also have what's called norms associated with it. So shoulder flexion norm is 180 degrees. So if my patient only has 140, Okay, we're missing 40 degrees. Let's go fix that. So that's where we get to use our goniometry for. How do we treat it? Well, stretching techniques. There's a lot of different stretching techniques we could use. We could also throw in things like foam rolling. I'm a little suspect on that, but we could. The other category of things we could use is joint mobilization. So joint mobilizations would be me stabilizing this femur, grabbing the tibia and sliding the tibia back and forth on the tibia to actually move that joint around. Now, there's some reasons we would do that versus stretching. If they have tight hamstrings, do you think me sliding the knee back and forth like that, is that going to help the hamstrings? No. But if they had meniscus tear and they had that there's a mechanical problem within that knee, joint mobilizations can really help that. So it just depends on what is the injury and what do I measure, and then how do I think the treatment will better impact those measurements because of the injury. Do you see how it all ties in over and over again? Yeah. After a knee replacement, restoring range of motion is really important. You need 105 degrees of flexion in the knee to walk downstairs safely. So we try to get 120 degrees for everybody, but as long as we get 105, okay, you can walk downstairs safely. Anybody think of some patient functions that, first of all, what kind of patients get knee replacements generally? Older adults, yeah. I see them frequently sub 60s now. When I first started, that was rare. I see it, it's not every day, but I see it more and more common to be below 60 and getting joints replaced. Yeah, there's a few reasons why we're doing it earlier and earlier. One, surgeons make money doing surgery. So it's like asking your barber if you need a haircut. It's like, yeah, sit down. So one of the reasons we used to say wait as long as possible before you get your joints replaced is because the components of that would last 10 to 20 years depending on activity level. Those components are lasting way longer, so there's less concern. The surgery techniques are also still a lot, but they're not quite as severe as the old versions, so they're taking less and less bone away as we do surgery. So there's a couple reasons. The surgery techniques are better. The technology of the components that are implanted are better. And the thought process of when do you want well-working knees? When you're in your late 50s and early 60s, or when you're in your 70s and 80s? I want to walk around more when I'm 60 than 70 and 80. Like, so the whole point of physical therapy is restoring life. The whole point of a joint replacement is restoring life. When do I want to live that life? Kind of right now, so that's another reason for it. Thinking of prior level of function, anybody think of some function for our older, 55 and up, older adults, we'll call it, that we would say, okay, you definitely need a lot more range of motion than just 105 degrees to walk downstairs. Think of any life activities that potentially hiking, maybe. Anything else? Yeah. In and out of shower, if we have a high tub bench, like a high step to get in and out, potentially. Or you talk about sitting down in a bath, maybe? Could be. Yep. Any others? Yeah. Yeah. Yeah, sure. Yeah. Yep. Absolutely. You never know what kind of recreational activity that could be. Yeah. Yeah. Stuff that we would never. Some of the most fun stuff is when patients come to you and say, well, I do this crazy thing. And you go, I don't know anything about that. Tell me everything. And I will try to figure out how to make this better for you. Yeah. Getting up from the toilet. Absolutely. Especially low. Anybody ever go into a bathroom and the toilet's really low? You go like, who is using this? Yeah. 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 Oh, yeah. All right. Yeah. Yeah. Yep. Yeah. Driving, definitely. Yep. How about gardening? Yeah, anybody's grandmas love to garden. You know, that's an activity. Um, the hardest ones for me are the little ladies that tell me that they need to kneel in church. And I try to tell them like, no, you get credit. You're there. You don't have to actually kneel. They say, don't you? I'm a lot closer to meeting him than you are. I'm going to be kneeling. I said, okay. We'll work hard on that. So yeah, that prior level of function, we know we need 105 degrees to walk downstairs. We can get you there. Want to kneel in church? We got a lot more work to do, right? So that's how that prior level of function can definitely change our plan of care and what we're trying to get after them. All right, so I want to talk about a couple common injuries. First up, ankle sprain. What's the anatomy involved? The anterior talofibular ligament, abbreviated ATFL, that's the most commonly sprained ligament in the body. So when you guys, in just a couple weeks in your anatomy class, you start looking at bones and ligaments and muscles, find that one, okay? The mechanism of injury is abnormal load. Now, it's abnormal load. It's really the direction of load. So this basketball player, you know, he's been jumping down, up and down on his legs all day long, all for his whole life. That's not abnormal load. It's not like somebody's hanging on his back and creating like that abnormal load. But some reason his foot turned in and the direction of load on that ankle was too much. So the treatment, well, we said in musculoskeletal, pain, range of motion, and strength are the big three. So we're definitely going to do that. For ankle sprain, it's the ankle dorsiflexion, right? Plantar flexion is pointing your toes straight out. Dorsiflexion is pulling your toes kind of towards your butt, towards your up towards the ceiling if you're standing. That's the motion we need to restore after an ankle sprain. The peroneal muscles, sometimes called the fib. I have a friend who's a foot surgeon, and she calls them fibulars because they run next to the fibula. Anybody already take anatomy? You guys know what I'm talking about when I say fibula, right? This little bone right here. So these peroneal muscles come down, they swoop behind this malleolus, and they attach to the foot, and they control the foot moving. It's my right foot moving towards that wall, right? So that motion there. So if we strengthen that musculature, it's going to help hopefully prevent this ligament from being sprained the next time. With an acute ankle injury or acute ankle sprain, the next thing we have to do that's a little bit unique to this is control swelling. So we've got to get rid of that swelling as fast as possible. Anybody sprain their ankle, puff up right away, right? And then doesn't anybody ever do it so bad they can't fit in their shoe? Have you? So, all right, if we have so much swelling we can't fit in our shoe, how does that affect our function? A lot. One, we get to walk weird. Two, do I even have footwear to use? If it's in the winter, maybe I can only wear sandals and I can't wear actual shoes. All right, if I have to wear sandals and not shoes, do I want to walk in 2 inches of snow? Right? I mean, so that's how a little ankle sprain can really affect our current level of function versus if we attack that swelling and get it down and we can fit in the shoe. How much function do we give back to our patients? Yeah.
When I went to PT for ankle, they were saying that right.
So there's some if there's enough swelling where we can't fit inside of the shoe, we got to get rid of that swelling because the swelling is directly impacting the function that I need for today. The rest ice compression elevation, we used to say do it for everything. The rest part is the most problematic now because especially with a sprained ankle. We used to say sit on the couch, put your foot up, put ice on it, and don't walk until it feels better. Well, that actually prolongs the pain and injury. What we want to do is attack the swelling and also use it a lot. So that's where some of the problem is. It's really the rest piece that is bit. So controlling swelling, icing, compression, elevation, medications, non-steroidal anti-inflammatories can also help as well. So really controlling that swelling is another one for this ankle sprain that particularly would be important. Osteoarthritis, you guys want to talk about it again, so why not talk about it? So osteoarthritis, the anatomy involved is the hyaline cartilage on the ends of weight-bearing bones. So you see how that's super, super white. So that hyaline cartilage, super slick. And what happens is that cartilage begins to wear down. It has little potholes in it. You guys ever drive on a brand new paved road? You guys ever drive on a road that hasn't been touched in years and there's a bunch of, how does the car feel when you're driving on that? Right? Bum, 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 bum. That's what walking on an arthritic knee is versus a freshly paved or perfectly smooth with hyaline cartilage. You can kind of see, like, if we think of it as roads, kind of freshly paved. All right, little problem, little cracks here and there. Still not bad. But got a little pothole. Got to go around that one and now take a different road. Right? That's what this one is. So that's the progression of osteoarthritis. Now, we already talked about it. It's a progressive condition. Ankle sprain, temporary, static. We'll get this better. Osteoarthritis is progressive condition. So our big three treatments are really important here. Control the pain. Pain is going to be part of osteoarthritis. But different from the ankle sprain where they're going to have pain just a little while, few weeks. Somebody with osteoarthritis, they're going to have pain up and down every day, right? So now the education of how to manage your pain versus let's just take it away, you'll be fine in a few weeks. So that's a lot different in how we're going to do it. Restore range of motion as much as possible, but maximizing the ability for the joints above and below the problem. Anytime we have a problem that we can't fix, our job is to make above and below that problem better. So my patients with knee arthritis, and I work on their ankle and hip all the time, they always ask me, why are you doing this? The problem's at the knee. Well, I can't fix your arthritis, but we're going to be asking your hips and your ankles to do as much as they possibly can because your knee's going to do less and less over the years. So we're going to do the best we can getting your friends to help. And then strengthening weak musculature is always something we can do. Non-specific neck pain. So the anatomy involved adaptively shortened muscles like upper trap and levator scap. Those are the big ones in the back of the neck that are mostly concerned with. Mechanism, cumulative microtrauma. If we look at this picture here, this guy's probably been staring at a computer screen, maybe their phone a lot, right? Isn't that, if we just put a little phone in his hands, wouldn't that be exactly what we all look like, right? So that is the common mechanism of injury, that cumulative microtrauma of staring at a computer, staring at your textbooks and notebooks, studying all the time. I can't tell you, come exam time, everybody has neck pain. Why? Because everybody's studying way more and just kind of looking like this, right? So that's that cumulative micro trauma. No one thing. It's just 10 years of working this desk job and staring at his phone. That's all it was. It wasn't any one thing. Here's another thing. Who's got so you got a pretty heavy water bottle, right? Anybody, if you've got a heavy water bottle or even your backpack, grab it. Hold it close to you. How long can we hold this for? Forever, right? Hold it straight out. And even with just our water bottles, I think we can hold it. How long do you think we could hold it? Less, right? All right, do this. Hold it straight up if you can with your shoulders, right? How long can we hold this for now? A lot longer, right? Why? So yeah, gravity is just pushing all of the weight through my joints and the forces being distributed to my body. When it's out here, what's happening? Gravity's pushing my arm down. My muscles have to kick on to hold it on. All right, so if we have forward posture because of our computer and desk work, do you see how if I've got good posture, gravity just pushes my head into the rest of my skeleton and no muscles have to work hard? If I have forward head, even if you haven't taken anatomy yet, these muscles all attached here, what do they have to do to my head now? They have to pull on it, right, to keep my head from just looking down, right? So because I want to look at my class when I teach, I want to look at the horizon when I drive. So all of those muscles have to kick on and hold my head. If we same thing as holding your water bottle out this way. Eventually your shoulder gets tired and is going to be sore, right? That's the exact same thing that's happening with this forward head. Do you see that? Sometimes with the smaller muscles, it makes it a little tougher, but if you just do this part, it makes a lot more sense. So what do? Control pain, restore range of motion. The restore of range of motion will hopefully improve this posture. That's what we're really looking for. And the tool we use to measure posture is called a plumb line. This is, you see this little dotted line? To make it a plumb line, you just hang a string from the ceiling with a little weight on the bottom, and it's just a nice vertical line. The patient stands in front of that, and then we get to see how far off from the center are they. It's pretty fun. And then strengthen the weak musculature that we need to. All right, any questions on that? Anything that we talked about today? All right, so I want to ask a couple things about studying and how we're doing. Who knew we were talking about musculoskeletal this week because they glanced at the material ahead of time? Good. That's what we should be doing. Preview before class. At least you know what you're walking into, just like watching a trailer for a movie and knowing if it's a comedy or a horror film. If you think it's a comedy and the guy starts, slashing people, you're in for a big surprise. This isn't that funny. Why is this? So, always for every single class, preview. If I haven't posted the material yet on the syllabus, I'm just telling you what chapter we're looking at. Just flip through the chapter and look at the pictures and big words. Just familiarize yourself with the topic a little bit. 5 to 15 minutes, not a lot of time. So learning is reps. That's all learning is. There are some classes that are low rep and some classes that are high rep. I think anatomy is a high rep class. There's a lot of stuff to it. There's really not even a lot of thinking to it. It's just memorize, here's 100 things that'll be on the test. I hope you know it. It's kind of easy because of that, because there's not a lot of thinking. I think your physics classes, or even this thought process of prior level of function, injury, what are we going to measure? How are we going to, that's a tough topic to understand, but once you get it, it's like nice. Anatomy is just reps, just a bunch of reps of a bunch of different things. I will also say you have high rep instructors and low rep instructors. What I mean by high rep instructors are, have you ever had a professor that's just sitting there and just checked out? They're just talking, they're just reading the slides, they're not like engaged or like trying to make sure you're following that, right? So you're probably going to need to do a lot more work on your own when you have that. How many people have had a great instructor other than me? Great instructor that's engaging, that like, it doesn't have to be college, maybe even high school and middle school. Like you can think of that great teacher that was like almost entertaining in the way that they tried to get you to learn, right? Those instructors are low rep instructors because they communicate to you better. As good as I try to be, I don't communicate to everybody well. The artistic people that like songs and dances and coloring and drawing, like I'm not an artistic person. I am, here's the chart, here's the steps, learn these 5 things. Like I'm very concrete. The concrete thinkers that like that think I'm a great teacher. The ones that are more artistic don't understand. We don't understand one another. So you have high rep topics, you have high rep instructors. And sometimes it's high rep just because it's tough, and even if you have a good instructor, right? So previewing before class is a rep. 5 to 10 minutes. Showing up to class is your biggest rep that you get. After class, you should be reviewing. Now, your review could be as you drive home thinking, what did we learn today? What were the couple of things? What didn't I understand? Now, the next thing is to review again. Now, how many people didn't study anything for this class in the last week? It's okay if you didn't. But how many people didn't open up a textbook or notebook? They just showed up to class today. Everybody learned a little. Nobody's willing to say like I didn't do it, right? In other classes, do you guys just show up to your class not knowing, not reviewing the stuff you learn? You guys are such better students than me. Math class? Is that because you get math and it's just easy for you, or? Gotcha. All right. All right. So what I will tell you is, if you look at the stuff we just learned today, tomorrow, you'll have forgotten between 10 and 20% of the information just because you're looking at it tomorrow, just because of that gap of time. If you look at it, tomorrow's Friday, if you look at it on Saturday, 20 to 30%. Sunday, 30 to 40%. Monday, 40 to 50%. If you wait till next week, forgotten 80 to 90%. If the next time you think about ankle sprains is next Thursday, you'll have forgotten the bulk of the information. So studying 20-ish minutes a day, and this is for all your topics that you learn, studying 10 to 20 minutes a day is usually more beneficial than studying for 4 hours on a Sunday, because of the gap of time that you've already forgotten information. Does that make sense? Does anybody, when I say that, does that make sense? Can you think of an example of a class be like, oh yeah, when I do that? That's why I hate once a week classes, because the gap in time between us talking again is so big. So if you're not doing your job, I can't say, how come nobody looked at this in the 2 days that I saw, right? So I hate once a week classes for that reason. So, and then do you need to, some things are going to come easy to you and other things you're going to have to study a bunch. I bet you most people in this class, this musculoskeletal stuff, does it feel easier to learn than the stuff of last week, the APTA stuff? And I think it's just a little bit more interesting. It's kind of what you want to do, so there's an emotional pull to it. So this stuff, you might need a few reps on. The first week stuff, you might need a lot more reps just because the topics are engaging or not engaging. So here's what I want to know from you guys. This is going to lead us into our homework. You guys said that you've already studied for this class, right? I know you did because we talked outside. Anybody else already start studying for this class? Recapping, looking at notes. How do we study? What are you doing to study? How do you learn? Whether it's my class or a different class. Okay. In the textbooks, the little quizzes. Yeah. Yeah. Perfect. Yeah. That's the next thing is testing our knowledge. We'll get there. Any other ways we like to study? How do you like to study?
Scouting all the information, turn to a summary, and just get the most important.
Boy, what a great tip. Get the biggest pieces of information, kind of scan everything, get the most important information, really focus on that stuff. Yeah. A little bit easier in this class, a little tougher in your anatomies because anatomy, it's everything. But yeah, yep. Any other ways you like to study? Videos. Good. So these videos are going to be great for you. Any others? Yep. Yeah, I like charts and I like connecting information. Yes, these things are like this. Yeah, I love that. That's how I learn too. Anybody a flashcard learner? Anybody love flashcards? Walk around? No. Yeah, you are. That's okay. I was never a flashcard learner. Some things like anatomy are a little easier with flashcards than other topics. But some people, I see some students just have, big old stacks of flashcards, and that's how they're going to learn. How about Quizlets? Anybody like a Quizlet? Yeah, Quizlets are pretty good. I like quizzes because you have to make the questions, and potentially there's someone else that has taken it and made their own questions too. So there's like a double studying. Writing a question is part of studying, and then answering the questions is the next thing of studying. So here's what I want for your assignment. I want you to share with the class some method that you use to learn of the topics we talked about. So we have 2 weeks of material. Now, where are we going to get the most important? So, right, the most important information is looking at the learning objectives, because that's where the exam questions are going to come from. So if you like writing Quizlets, what are your 3 questions on 2 of these learning objectives? If you're a flashcard person, what are your flashcards for these things? Because someone who's not a flashcard learner is going to have a really hard time making those. But here's what I know. Anybody like mnemonics, especially if you're in anatomy, those are good. So that's the ways you can remember things like the cranial nerves. Oh, once one takes the anatomy final, very good. Vacations are heavenly. Optic, oculomotor, right? You guys know what I'm talking about? The carpal bones are another common one. Yep. Anybody know what I'm talking about? So if you're a mnemonic person, maybe you come up with a mnemonic just to say, like, here's how I'm going to remember these tasks. If you're a song and dance or an artist that likes to draw, tell us how you're doing that. So we're going to make this a discussion board assignment. If it's just, you can write in a post, here's what I did. You can, if you create something, a drawing, a flashcards or Quizlets, I ask that you upload a file or, write what you did. And then hopefully at the end of, we'll be able to look at this and look at all of the different ways we studied. And someone that is having a hard time describing anatomy involved mechanism and treatment of those 3 injuries, one of our study approaches is going to work to remember these things. Okay? All right, we'll make this let's make it due Tuesday by midnight. That way I get to look at it on Wednesday and we get to talk about it on Thursday. I'll put it in Blackboard. It'll be in the discussion board in Blackboard. Everybody's taken an online course and knows how to work around discussion boards, right? If there's a problem, just email me and let me know. And I am going to leave this nice and broad. I expect you to do a good job. But again, we're creating this class together. So we have all of these objectives. We have all of the objectives from the first PowerPoint. If you want to do something for every objective, great. You're only studying and helping your classmates. If you said, you know what, for this assignment, we got a hurricane coming. I got nothing but phone calls calling me. I had a tree fall on my house, whatever it might be. If you do a good job with one or two of these, that's fine. Just do a good job with what you got. Okay, we'll leave it nice and broad and go from there. All right, sound fair? All right, that's it for us for this week. Any problems, let me know, okay? Thanks for all the fun, guys. I hope it was entertaining to you.